Good morning, everyone, and thank you for coming out to another edition of Disability Pride Virtual PA. Our job is to make Pennsylvania disability proud. Today, we have a wonderful event from Staunton Farm Foundation. It's called Everything You Want to Know About Substance Use, but We're Afraid to Ask. And what I'm going to do, my name is Vicki Landers. I am the founder and CEO of Disability Pride PA. I'm going to be going over some housekeeping rules. One of the first things I want to make sure that I do is to let you know what I look like. So I am a middle-aged white woman. I have purple hair and purple glasses. I have headphones over my ears today because there's a lot of noise in my background. And I have a picture of wheelchair art in my background and a sign that says what disability pride means. So thank you everybody for joining us. And we're going to get this kick started. I'm going to turn this over to Bethany Hemingway. She is going to get this started for everybody. Hi, Bethany.
Thank you, Vicki. Hi, everyone. I'm Bethany Hemingway. I am the Senior Program Officer at the Staunton Farm Foundation. We are located, before I begin, I will do an image description of myself. I am a white woman. Currently, my background is blurred, but I am wearing black glasses, frame glasses with headphones on, and I'm wearing a green shirt. So today we are going to talk everything you want to know about substance use, but we're afraid to ask. I have 4 wonderful panelists here to talk about recovery, substance use disorder, and everything you want to know. So basically, before I begin, Staunton Farm Foundation, we are a local foundation located in Pittsburgh, Pennsylvania, and we fund Southwestern PA, 10 counties, and we fund mental health and substance use disorders. I'm not going to go into detail about some stats that I've uncovered because Naomi will talk a little bit about some disability and substance use stats that I've heard from her first place, so I'm not going to steal her thunder. But first, I would like to introduce to you our first panelist, Dr. Jonathan Hahn. He is a family physician, primary care doctor, and now an educator and teacher at UPMC St. Margaret Family Medicine Residency Program. He and his team have implemented an integrated behavioral health program incorporating on-site behavioral health clinicians as well as pharmacists in their family health care center for over 10 years, and they have provided substance use disorder services and medication assistant therapy for opiate use disorders for several years. So first of all, Dr. Hahn, welcome and thank you for your time for coming. But I would first like you to first describe yourself, and also after you describe yourself, can you tell us a little bit about what is a substance use disorder?
Yeah, thank you. So I really appreciate the invitation. I'm honored to be here, and especially to work with Staunton Farm. And I'm a middle-aged Asian man wearing not dark glasses, but wearing glasses and sitting in an office. And my background is I'm Korean American, and I've been working in this community health center for about 20 years now, and we take care of a lot of people with substance use disorders. And there's the definitions of addiction specifically with substance use disorders. We look at it as a chronic relapsing disease similar to diabetes or high blood pressure, asthma, heart disease. It's characterized by people doing well and then people having relapses and not doing well, but it's an expected consequence of people who are struggling with substance use disorders. And it's also characterized by people having impairment of function due to the use of certain substances, and because of that almost compulsive use of other substances, that's where their functioning becomes impaired, and functioning on many different levels, of course, psychological, family levels, taking care of themselves, and being able to have a job. So we try to work very hard with people on an individual level to take care of their substance use disorders and to support them through the process, just like we would with any other chronic illness.
Very good. So also, Dr. Hahn, if if I was a person and did not know I was in need of substance use or treatment in general, and your PCP, my PCP, for example, I guess, how would you question somebody that would come to see you, or how would you start that conversation with a patient about substance use disorder, or when would I know as a patient of yours that when is time for treatment?
Yeah, those are great questions, because I think people in primary care today are working very hard to develop screening tools so that anytime you would come to a physician's office, a primary care office, and the staff is very interested in taking care of you holistically, they may have protocols in place where they ask you screening questions about whether and how you use substances. So we use a two-question, we actually use a two-question substance use screen. Some of it is written, some of it is administered electronically on tablets. So it kind of depends on you. And also these questions are written in terms of trying to be at about a 6th grade literacy level. Sometimes our nurses will screen patients as well, especially if you have an impairment and you're not sighted. So there are different ways to screen people. I personally screen everybody, no matter what they answer on a questionnaire. I will ask them myself in the interview room. I think everyone does things a little bit differently. I think right now there's such an explosion of kind of electronic screening tools that people use, but I tend to repeat everything when I'm in the room and ask people myself. Like, for instance, for alcohol use, I'll ask a person how much beer or wine or liquor they may drink in a week. And it really kind of depends on the way you ask the question, rather than presuming, like saying, you don't drink, do you, or something. But there has a lot to do with the verbiage you use to screen people. The same thing goes for illicit use of other substances or prescription opioids. So when we're talking about substances, it runs the gambit of alcohol to prescription drugs to illicit drugs, or harmful use of prescription drugs such as pain medicines and opioids. So there are a lot of screening tools in place that primary care physicians are using, and we train residents in our office. So we're a very large training program. So we want to teach our residents and future physicians in the community to be very aware of the way people use substances and to look for markers of abuse or misuse, so that we can counsel them about how to avoid addiction and making sure that problems don't get worse.
All right. So now that you talked about some types of treatments and everything, and I just wanted to ask you about MAT, because there's a lot of talk about MAT and people might not understand what MAT is. Can you explain what MAT, and when we say MAT, that's medication addiction treatment. So what is that? And what type of therapies are there out there? What is it as a PCP doctor, as a family physician? If I had to come to you, what could you do for me?
Yeah, so medication assisted treatment or medication assisted therapies we know there's really great medical evidence for certain kinds of medications that we can prescribe to help people control their use of illicit opioids. Let's start with opioids. So there's Suboxone, which is buprenorphine, and naloxone. That's one of the most effective medications next to methadone to treat opioid use disorder. And we can do that from the office, and it's easy to prescribe, and we do that in working collaboratively with a team. So we have counselors in our office and people that can provide support and follow up for referrals or other kinds of supports that people need. So buprenorphine, otherwise known as Suboxone, is one medication. There's another medication called Naltrexone. It's also known as Vivitrol, and that comes as an injection. You can also use it as a pill form, but it's probably better for opioid use disorder to use it as an injection, whereas we use the pill form sometimes for people with alcohol use disorder. So there are very effective medications that can help people with opioid use disorder and alcohol use disorder. These medications have been shown to decrease overdose, to decrease mortality, to improve functioning. They're very effective, and they can be done. You can receive these medications from a primary care physician's office, which is a wonderful way to improve accessibility, because I think it decreases the stigma that's out there in society, as all of you know, in terms of trying to get support for substance use disorders in other kinds of facilities. But primary care offices, many of them are offering these services and these treatments now.
That was one of my last questions I wanted to ask you about, was the like coming to see a PCP versus a traditional, like a rehab treatment facility. I mean, obviously, I'm the believer that there's no wrong door to receiving treatments, but you mentioned about being more accessible in PCP treatment. Do you have anything thoughts about like going a PCP versus your regular rehab traditional route? Like, do you have any thoughts or opinions about it? Not putting you on the spot or anything.
Yeah, well, I think that there's so much stigma, as you all know, that's associated with substance use disorders. And what I'm glad to see over the last 20 years, especially, is that I think education and medicine is really moving towards removing and trying to decrease that stigma by our terminology, by looking at addiction as a chronic illness, just like diabetes or high blood pressure or chronic lung disease, and trying to get more and more primary care physicians to prescribe these medications because they're safe, they save lives, they're very effective, there's great medical evidence behind it. Many of the traditional rehabs that you would go to, or rehab facilities, so many of them actually do not offer medication treatment because they're based on a sobriety model. That works for some people, but it doesn't work for all people. And I think trying to treat a problem as complicated as addiction, I think we need several different kinds of interventions because it's not a one-size-fits-all model. And we know that in primary care, medication-assisted treatment is very effective. And I think people feel more comfortable going to a primary care office where they can get these services rather than even facing the stigma of trying to go to a rehab facility or a detox facility.
Thank you, Dr. Hahn. That was a great overview of like substance use and what also substance use disorder, and also just the type of different therapies and treatments out there. So you're off the hook for now, and I am going to basically move it over to Jess Williams, who's the coordinator of an annual event called the Pittsburgh Recovery Walk, which is held every September in downtown Pittsburgh, except for last year. It was virtual, I believe. Yes, Jess. It's designated to celebrate the many paths to recovery from addiction and all those who travel them. She is currently a social work student at the University of Pittsburgh, and before that, she worked in the field of addiction for 10 years. She's also been a volunteer with Pittsburgh's Needle Exchange for over a decade. She struggled with her own addiction throughout her 20s and started her process of recovery in 2012. So Jess, welcome. And so first and foremost, I want you to, if you would want to share some of your story, your recovery story with us, I would really appreciate that. And then also I'm going to be asking you a little bit about harm reduction in a few minutes. So please tell us a little bit about you, Jess.
Thank you so much, Bethany. And this is very funny. I will do my best to describe myself, but I feel like on the spot about whether I'm middle-aged or not. I think I'm on the cusp of middle age. I'm also white. I have short, sort of disheveled hair, and I have a big toothy smile. So I'm so happy to be here and to learn from the panelists here, and also hopefully to get some perspective on what it's like to be a person with a disability thinking about substance use and substance use disorder, because I have a lot of ignorance and I have a lot to learn in that area, I think. So I will, maybe I could tell my story for like maybe 5 minutes or so, Bethany. Someone needs to give me a limit, or
yes, you could give a brief 5-minute story about yourself and then we can go into it. Yes.
Good. I started my sort of recovery process in 2012, as Bethany mentioned. And I think I was really sort of primed to have issues with addiction from a young age. I was thinking today about just all these kind of flashes of memories about a feeling of badness and wrongness, and that I couldn't be weak or ask for help. And I think those messages came to me through my family and through school and sort of the society that I grew up in. But by the time I sort of got to college, I had this mentality that nothing good could really happen for me, and it was my fault. And so I was very sort of overjoyed when I found that marijuana and alcohol sort of cured that that thought and feeling experience. And naturally it was temporary, but it was so important to me to have a respite from that sort of mental place that I lived in. And so in the ensuing years, so for about 10 years, I was drunk and high nearly every day. And the significance of drugs, and when I say drugs, I include alcohol, was just profound for me. I could tell that maybe other people were finding like fun or recreation in their use. And I was too, but I was also sort of like, it was deadly serious for me to escape the person that I thought I was, which was not acceptable or good. So I could see that substance use was sort of a dead end, in the sense that I had the same sort of stigma that everybody, or that most people have about addiction, which is I didn't want to be a drug addict or an alcoholic, but I also could not stop using because I didn't want to face myself and kind of the days and years of my sober self and the reality that I lived in. And so there's just a number of funny turns of events in my life. And one of them was that I moved to Pittsburgh. I bounced around as one does when they're trying to escape themselves. And I moved to Pittsburgh and I got a job at a nonprofit called IRETA that does training and consulting about substance use disorder and addiction treatment. And I, at the time, felt like I was in this very weird and tight spot, which is that I was certainly struggling with my own issues, but I was sort of passing for like a regular person. And so I got into this job where I started to learn about recovery. And I just didn't know that people got better. And I see that as being a really big problem. And it's a big, what sort of fuels my work in the recovery walk too. And so I started reading blogs and I started talking to people in recovery. And that opened up a little sliver of hope for me that I didn't have to keep living the life I was living, which had, by that point, had a lot of deception in it. And so my path did not involve formal treatment. It involved community support groups. And that actually is sort of fairly common. I think there's a lot of misconceptions that I think it'll be fun to talk through. But one of them is that you have to go to treatment. And we know that many people don't want to go to treatment. Many people don't go to treatment. And yet it's fairly common for people to find some sort of recovery from their addiction. And so for me, there was a meditation group, which is still going on. I can't speak highly enough of it. In Highland Park, it's called, there's a Shambhala Center and they do a meditation group. And they had a little flyer that they put out into my local neighborhood coffee shop. And by this time I had gone to therapy for the umpteenth time, but I told my therapist that the truth, which is that I never wanted to be sober, and he encouraged me to find community support. So I bravely went to this group, and it was a very gentle group. And over the course of several months, I made what was a very painful decision for me, which was to stop using drugs. And I realized that I needed more support. And so I ended up doing a lot of things. I went to my PCP and I said, I think I have some sort of anxiety disorder, and I tried antidepressants for the first time, which actually were quite helpful for me. And I got involved in 12-step. And 12-step has been a really wonderful path for me, very supportive for me. At the same time, I stayed in therapy, and I made changes in my life in terms of the way I spent my time and the people I spent my time with. And all of that I found really quite difficult. And so I think that's probably, is that enough for my story? Yeah.
I mean, your story can go on. Our stories are still going on, but I
Great.
think you hit some really great points there. That you talked about the Shambhala Center, and I think a lot of people think that AA and NA are the ways to go. And it's not necessarily. There are other types of groups out there. We're going to talk about some more of these other groups, but I know there's Dharma Recovery, which is another meditation group that basically it comes from a place of empowerment where you're more about it's based in trauma, whereas AA is like you were powerless to the drug. So it's different strokes for different folks and different flavors for what out there. So I encourage people to just research what's out there in type of mutual aid groups, because there are all so many different ones out there with so many different supports. So thank you for bringing that up, because I like people to know that AA and NA are not, they're there, but there's other groups that have been created now within the community. You also talk a little bit about, I wanted to ask you about harm reduction, because I don't know what people know about harm reduction. And I know you've been in this work and have been hanging out with people with the sterile needle exchange, and that has to do with harm reduction. Can you explain what harm reduction is and how it pertains to substance use disorders?
Sure. Yeah. And I know Dr. Hahn is also a volunteer with the needle exchange and probably uses harm reduction in his work all the time. I think a simple way to think about harm reduction is to look at behaviors and to consider whether or not they cause harm, where the harm is, and if that harm can be reduced. And I really like it as an approach because I think it doesn't, sometimes we have these rigid categories where like doing drugs is bad. But I think what seems to be a more important question for any given person is doing drugs causing harm? And if the answer is no, then more power to you, you know? But if the answer is yes, what are some strategies we might employ to reduce that harm? There's really all sorts of kind of like interesting and exciting ways, I think, to reduce harm for people in a way that does not require them to cross lines that they are not willing or able to cross. And in terms of harm reduction, the needle exchange is a great example. People that come to the needle exchange, I think, and I'm sure Dr. Hahn can attest too, that they are people who are really being thoughtful about their own health, and they're doing something that is quite stigmatized, but they are trying to protect themselves and the people they care about from transmitting or becoming infected with diseases or from overdosing. But I see harm reduction as being part of my story too, and I'll give an example. And this is where I think that these divisions between sort of like abstinence-based and harm reduction just really fall apart when you start examining them. Because the first year that I was in recovery, I went to lots of 12-step meetings, and I, at the time, was smoking like a chimney. And I also had a binge eating disorder, which I'd had for years. And people in 12-step encouraged me to smoke and to eat as much ice cream as I wanted to, which to me, that was them employing harm reduction tactics, which is saying like, what is causing the biggest problem in your life? And like, those are the behaviors that we're going to address, and you don't have to change these other things right now. And so I think like life is only ever harm reduction. So yeah.
Thank you for that explanation of harm reduction, because I know that I get caught up when explaining what harm reduction is. And I'd like just to say it's like doing less harm. That's
Mhm.
basically, if you're basically deciding you want to quit alcohol, or for example, when medical marijuana was available for patients for opiate use disorder, a lot of people did not understand that. And I was using that harm reduction frame like, well, they're not going to be using fentanyl or heroin, and they're going to be vaping marijuana. What is worse?
Mhm.
And just to get people to understand that framing, because I think people just think you're substituting something for the lesser evil, but in a way it's just like keeping people alive and healthy, in a way to think about harm reduction. It's just I just don't know if a lot of people know about what's the harm reduction, why it's so important in the work in substance use disorders. But you don't have to answer that one. So as someone that you are living in your recovery right now, is there any challenges or anything in a daily, I guess, you want to share that come up even when you see doctors? And I also want to say that your comment about disability, that under the federal law, addiction is considered a disability. So that is something like, do you yourself see you as somebody that can have a label considered disability under addiction, or like, is that something that you're just starting to think about?
Yeah, that was new to me. I guess I understood that people were protected, they were able to go to treatment and their workplace was required to support that. But I don't personally identify as a person with a disability. Um, and I think that there is a lot of rhetoric, particularly in the 12-step rooms that I circulate in. And I feel a little bit inclined to say that 12-step is such a diverse and varied landscape that there's really no way to speak about it as one thing. And so the folks that I know, the meetings that I go to are limited. If you, for example, have been to an AA meeting and didn't like it, you may find another one that actually suits you much better. But I think that there is, as Dr. Han talked about, this idea that you have a disease that will always need to be sort of kept in remission. And even that, I think, is like somewhat contestable. I don't know that I even fully believe that about myself. However, I think that life is challenging for me on an emotional level, and I need help as a social animal. And I find that help from people that have helped me with my recovery or that loved ones in my life. And I actually think that's pretty countercultural in America, where we're all supposed to be rugged individualists. And and then we kind of feel like we failed when we need help. And so turning that notion on its head and saying like, that never was true of me. I've always needed help. And can I build that sort of support into my life now, has made me a person more able to face the day,
Thank you, Jess. I love that at the end. Thank you for sharing your story with us as well, and just educating us on harm reduction. And now I'm going to turn it over to Naomi Gonzalez, who is a Latina female born in New York and resides in PA. She's a single mother of 4 amazing children, one whom has autism. She is currently working towards her degree in addiction psychology in hopes of working in treatment facility as an interventionist and therapist. Naomi is currently an ambassador for Miss Wheelchair Pennsylvania organization, which the platform is shining light on inaccessible treatment facilities. And she created the first public recovery support group for people with disabilities. Hashtag sobriety possibilities for PWD. I'll put that in the chat box. And she partnered with Disability Pride PA, Liberty Resources Incorporated, and Wheel With Me Foundation as a consultant, providing resources for those within the disability community that struggle with substance abuse. In 2019, Naomi had an emergency surgery, which left her with an incomplete spinal cord injury. So Naomi, thank you for joining us. Thank you for also last minute. I got Naomi last minute. I heard her story and it was just like, we had to have her here. First and foremost, I wanted to ask you, what is an incomplete spinal cord injury?
So thank you for having me. An incomplete spinal cord injury is basically when there is damage done to any part of your spinal cord, or damage done to the nerves in the spinal cord.
Thank you. I just, when you wrote that to me, I did not know myself, and I just wanted to ask you. So can you explain also, I heard some statistics you talked about in an interview with Dr. Rachel Kellum Whitman in May about people with disabilities and substance use disorder and that intersectionality. And I did not know that information. And can you talk a little bit about that? And also just also a little bit about your story and who you are.
Sure. So very early on, I experienced childhood trauma, mental health complications, and I grew up with an alcoholic father who displayed toxic behaviors. And I believe that that played a huge role into my adulthood trauma, into my unhealthy behaviors, toxic relationships, and domestic abuse, alcoholism, and substance abuse. I struggled with those three half my life. And I entered something like 12 plus treatment facilities, in and out of relapse, in and out of recovery. And I decided to give it yet one more try. And this time I was able to do so without entering treatment, without AA, without NA. And I finally started getting my life back on track, and boom, 2019, needed this emergency surgery, resulted in my paralysis, making me a full-time wheelchair user. And so being that I would now experience chronic pain, doctors offered me some pretty serious pain medications. And I immediately knew that I had to decline because of my previous history with substance abuse. And so I decided that the best option for me at that time, being that, so while I was inpatient, I was already on some pretty serious pain medications, being that I had just gotten out of surgery. So I decided that the best approach for me would be to get on Suboxone sublingual films. I then went on to the Sublocade monthly injection, which Dr. Hahn touched base on. Then I tapered back down to the Suboxones, and then I completely became free of any Medicaid-assisted treatments and therapies. So fast forward about a year later was when I joined the Miss Wheelchair Pennsylvania organization. And I knew, knowing that how close I is, and could potentially always be to experiencing a relapse and substance abuse, I started researching what substance abuse looked like in the disability community. The more I researched, the more I was convinced that this is who needs advocating for, because the disability community is up to 4 times more likely to experience substance abuse compared to the general population. Yet treatment facilities are not exactly accessible. Most treatment facilities are not equipped to treat someone in a wheelchair, to treat someone who is blind, or anyone in the deaf community that happens to be struggling with substance abuse. So right now we're working up to 5 million Americans within the disability community alone that struggle with substance abuse. And I think it's important that, the world needs to know that addiction can and will lead to a physical, invisible, or mental health disability. And when I say invisible, it could be chronic pain, it could be an array of different things. And it's not necessarily always going to be due to long-term use. It could happen way before then. It could happen due to accidental encounters. Being a part of this community now, the disability community, I've met so many individuals that have an array of disabilities due to their prior addictions. And in the same breath, a physical, invisible, or mental health disability can absolutely lead to addiction as well. You're on pain medications, and they are most certainly dispensed to someone that has a disability with almost no questions asked. Now, today, they're taking more precautions, but it is a lot easier for someone who has a physical disability or chronic pain to receive those pain medications. And as we all know, eventually, people will develop a tolerance to opioid pain medications, which then goes from substance use to substance misuse to substance abuse, not to mention the associated situational discomforts and mental health, and just trying to be accepted by society to fit the standard mold can really lead someone with a disability to become a daily drinker or to abuse their pain medications, which in turn then could lead to the harder opiates. And truth be told, many substance use disorders are misdiagnosed as mental health illnesses, and many mental health illnesses are misdiagnosed as a substance use disorder. Treatment then becomes impossible if the diagnosis isn't being made. And, you know, when I first became disabled, I looked for support, and I found so many support groups for people in recovery. Great. Found a ton of support groups for people with disabilities. Awesome. I just knew with these statistics, I would find something for a combination of people with disabilities that are either in recovery or wanting to be in recovery. None. And I'm thinking, well, maybe I'm just not searching it right. Started asking, the support group, nothing. I almost fell out of my wheelchair. I'm like, how is this impossible? There's no way that I'm the only one that, and so I said, well, that's got to change. And so I created, the first public one. Now, in all fairness, there may, or I've been told that there are private ones that you can't be invited to unless someone in it invites you to it, adding to the stigma. Why keep it under wraps? Share your story. The more you share your story, the more you're going to impact lives to change their own, to speak up. And I was ashamed. I was ashamed for years. But now I'm like, yes, I beat my addiction. I'm no longer ashamed of it. I figured out a way to beat it, and I want other people to do it too, because if I can do it, so can you. I used to despise, and no offense, I would despise people that would say, if I got clean and sober, so can you, like this commercial. No, you don't know my life. You don't know what I've been through, but no, I've been through it all. And someone that was so lost, I didn't even want to be found. Drunk and high and toxic. I wanted to stay that way. I was so mad at the world. And if someone like that, someone like me, can turn over that new leaf after so many different treatment facilities and figure it out, so can you. And just like Dr. Hahn said, I absolutely agree. There is no one size fits all approach for treatment. You have to find what works for you, whether it's with medication, without medication, whether it's in the rooms, out the rooms. Something is going to work for you, but what works for somebody else, don't compare yourself to that person, because it may not work for you. You have to find what works for you. And sadly, the opioid epidemic was already rising at alarming rates to begin with pre-COVID. And now these numbers are steadily rising post-COVID, not to mention because now a lot more disabilities have been stemmed from people that have, dealt with COVID-19. And so a disability can happen at any time. Substance abuse, as many know, does not discriminate. That can happen at any time. And I just feel like, why wait till then to start fixing the problem of inaccessible treatment facilities, which is why I go really hardcore when it comes to advocating for such changes.
Thank you, Naya. This is why we needed you here at this panel, because I was just very ignorant to the fact of just thinking about the accessibility of even NAA meetings. And I'm like, where do they most occur? Church basements, which are grandfathered in about after the ADA. So basically, people with wheelchairs, how are you getting there? You're not. So I mean, you really opened my eyes to a different issue that I was not aware of. And I really appreciate your story and hearing that. And because it needs to be known and to be more inclusive and more accessible for everybody to get treatment. We shouldn't be excluding anyone. So I'm just really happy that I got to hear you speak and open my eyes. Also, I wanted to ask you, since your accident, how was I was wondering, like, your experience with doctors, because you mentioned they're more willing to give people with disabilities, I guess I would say more those visible disabilities, maybe individuals in wheelchairs, opiates or on other types of substances. And how is that I guess, how does that feel for you to have those conversations with doctors or dentists or anyone that just basically, that knowing that you're someone in a wheelchair and also someone in recovery, do you feel like there has been a different shift since you've been somebody that has, since your accident? Or I don't know. I'm just generally asking.
It's actually quite a toss-up. It depends on if I'm going to the dentist, if I'm going to the gyno, if I'm going to my PCP, because with my medical history, it's in there that I had, issues with addiction. Doctors still wanted to give me opioid pain medications. They still wanted to give me ketamine infusions. They were still willing to give me an array of different addictive approaches to treatment and to pain. And then I go to the dentist, but they won't give me a Percocet for 3 days because I'm in such pain, because they now have it in my record that I, abused opiates. And so it's a toss-up. It all depends on where I go, who I see, and what their attitudes are towards people with disabilities that struggle with substance abuse. Now, I was able to, build a tolerance for pain. I pretty much had no choice because I'm at a point in my recovery that I refuse to touch. It takes everything in me to just take a Tylenol. I just can't stand pills. And that's where my addiction stemmed from, pain medications. So I know for me, I have to stay away from them. And yes, I have, in all honesty, I've took an Oxycontin that they gave me in the ER because I was in that much pain, but I refused any further prescriptions for it. I don't need it. I'm fine. I'm good. If it's that bad, I'll come back to the ER. But yeah, it just depends. It depends on where I go and who I speak to and what their attitudes are.
Thank you. Thank you for just being vulnerable and just sharing that with us too. Because I just wondered how you're just basically from your accident until now, like how perceptions of people have taken you, and just also being in recovery, and just how are attitudes towards you with that.
Absolutely.
So I appreciate you sharing those.
Just so you know, no offense, but no one really knows. I mean, some maybe, no one really knows of the issues going on behind closed doors when it comes to people with disabilities that struggle with substance abuse. So I myself didn't know. I didn't know until I crossed over and became disabled myself. And that's why when I found out, I said, this is a window that needs to be open for everyone to be able to look in and see what we can all do in terms of educating each other, raising awareness, and continuing to make changes. Thank you so much for having me.
Well, I appreciate you so much for being here too. And I'm sure our other panelists appreciate you as well, and our viewers. So we'll be back, and I'm going to move it over to Miss Sarah Schotlin, who is a literary artist, educator, and citizen. She is an author of the novel Junket and a playwright whose work has been performed in professional theaters around the world. She's the co-founder and program director of Words Without Walls, which brings creative writing classes to jails, prisons, and drug treatment centers. She also is the assistant professor of English at Chatham University, where she teaches in an MFA in creative writing program. And also Sarah is someone who's also been in a long-term recovery. So Sarah, thank you for coming on today and talking with us. So would you like to describe yourself first, a visual description of yourself, and also tell us a little bit about your story and how you got to here today?
Sure. Thank you so much for having me. It's been so awesome to hear all the other stories that have started us off today. I am white woman with longish, dirty blonde hair and a fringe bang. I'm in my office at Chatham, where you can see some very messy bookshelves behind me and a tote bag that says "Dangerous Women Read." And I'm wearing a cap sleeve black dress with a starburst yellow pattern on it. I'm wearing lipstick because it's a special day. So listening to everyone else's story, there were so many things that resonated with me. Dr. Hahn described substance abuse disorder as chronic and basically nonlinear relapses involved. And when I was very young, 10, I began engaging in bulimia. And that was sort of my first initial experience with a chronic, lifelong disease that I have to be mindful of every day, and that's progress and recovery is totally nonlinear. So I've had experience with that since I was 10. When I was 15, my high school boyfriend died very suddenly of a genetic condition in his heart's electrical system that no one was aware that he had. And he died suddenly and in front of me. And a week after that happened, I went to a high school party and I blacked out drunk for the first time. I dropped acid, I did cocaine, I smoked marijuana. And that was really for me, like puzzle piece event reaction. And I was really off to the races. That was 1996. Flash forward to 2005. So that's, 9 years in which my substance abuse escalated until the point that I had 3 years of daily intravenous heroin use. That was life-threatening and really affected every single relationship in my life. In 2005, I first sought treatment, and I had so many privileges when I started looking for treatment. I'm white. I already had a college degree. I'd had tons of positive, healthy, respectful experiences with doctors and nurses. I was not afraid of the medical system. And I trusted that doctors would give me lots of options when I presented them with a problem. I had also had experience with therapy because of my eating disorder and because of the trauma of my boyfriend's death. I had sort of been in and out of therapy for those things. So I was aware that they existed and that they would be options for me. So from 2005 to 2008, I tried sort of a throw everything at the wall and see what sticks method of recovery. I did things like therapy. I used MAT. So in that time, I used both methadone and Suboxone. I did a lot of harm reduction stuff. So like, I just set sort of lines in the sand for myself of like, I'm allowed to drink, but I do not want to use intravenous drugs. And if that's what I can do today, then I'm not going to beat myself up over whether or not my choice to drink today meets anyone else's definition of progress. In 2008, so I did that for about 3 years. In 2008, I felt as though I was sort of spinning my wheels, and I sought more treatment at a community health clinic in Austin, Texas, that was run by a doctor from the Netherlands who was in Austin, Texas, because he'd done a lot of academic research at the University of Texas at Austin around methadone treatment. And at this methadone clinic, which is very unusual, in order to remain on the program, you had to engage in weekly therapy sessions. You had to go to weekly group therapy sessions, and they had different sort of groups. So I went to a women's group, I went to a grief group, they had a book club. I got acupuncture there, I got therapeutic massage there, I got like rapid eye motion therapy there, and I got medicine there. So I was there, I think I was treated with methadone for about, let's say 3-4 months. And then I transferred to Suboxone. And I was prescribed Suboxone from 2008 until 2011. And from 2008 until 2011, I was able to free my mind of the obsession that came with the daily choice not to use opiates. That daily mental obsession was lifted, and in its place, I was able to imagine a future that involved all the other things that I was passionate about and wanted. For me, that included more education, and it included a career as a writer. It included seeing more of the world. And so in that time that I was prescribed medication from Dr. Ashbat, he was able to write me a prescription that traveled with me to Spain, where I was able to work in professional theaters in Spain, and he was able to write me prescriptions in Spanish. I was able to go to China for 9 months to work with bilingual theater artists. He was able to get me a prescription that I could carry on the airplane. I was able to apply to graduate school, move to Pittsburgh. He transferred my medication here. I will say it was much more difficult to find a doctor in Pennsylvania than it was in Madrid, Spain, who would be able to prescribe me Suboxone. And of course, in Texas. When I got here, I was very surprised at the difference between the culture of just the office waiting room for getting my Suboxone prescription here than the sort of culture of medically assisted treatment that I was used to. And I could see visibly and obviously that there was a stigma attached to this medication here that just didn't exist for me in the previous 4 years of recovery. When I came to Pittsburgh, it was for graduate school. I got an MFA in creative writing. And while I was in graduate school, I co-founded the Words Without Walls program, which brings creative writing to jails and prisons and drug treatment centers in Pittsburgh. I know that one of the key parts of my own personal recovery has been a daily writing practice, because writing is one of the tools that allows us to reflect on the past in service of reimagining our future. It allows us to marry parts of ourselves, our heads, our hearts, our hands, and to do a sort of holistic practice of reflecting on the self and sharing stories. And that work has really been a meaningful part of my recovery, because in the last 12 years that I've been running this program, I've heard thousands and thousands of people's stories of how they come to a crisis point in their life. And I've heard thousands and thousands of people's individual ways to imagine a path out to a new future. And that is an incredible gift for me in my personal recovery and in my life as a writer and an academic. Today, I use a variety of methods to stay healthy and sane and fulfilled and inspired. And that includes daily writing, it includes yoga, it includes meditation, it includes therapy. I still see, a therapist weekly. I go to an NA meeting that is specifically for people who are infected or affected by HIV and AIDS, because that group is full of people who understand that addiction is not about the substance. It is about your relationship to that substance. If it was not about the relationship to that substance, then you would be saying to somebody who has HIV, you shouldn't take your treatment because it's drugs and because it has sometimes psychotropic effects. Obviously, the people in this group are going to do that. They're going to take their medication, and they have to suss out the nuance of why that medication and that psychotropic symptom is different. And that difference is in the relationship. So that meeting has been extremely, I have learned so much in that meeting about my own relationship to drugs. And as my progress with my eating disorder continues, it is so clear to me how interlaced those behaviors are. And having a recognition that they're linked and that I'm treating them both at the same time, anytime I'm doing something good and positive for myself. Also, I think just makes my recovery feel even deeper. I will sort of wrap up by saying The thing that I feel most misunderstood in like the general culture of how addiction and recovery are presented is the obsession with the chemical, is the obsession with the external symptom. And in my experience, my addiction and recovery have been all about adding to my life. It's always been about what I can do next, what I can do more, what I can add to a fulfilling life. It has not been at all about subtracting people, places, and things. It has not been about subtracting specific substances. It has been about building a life rather than managing a symptom or a behavior. And that means that my recovery might look very different than someone else's. And this is still my story, and I'm still allowed to tell it. And I hope that we have a more expansive way to view treatment and recovery moving forward.
Thank you, Sarah. Wow. That relationship, building the relationship with the group that would just kind of was just a different way I've heard it framed to me. And I just also, wow, like never heard that one before either. So I really appreciate your vulnerable and your viewpoint about addiction, recovery, and the relationship is so important because you're right that, there's, psychotropic medications that people are probably on because I've been in this field for about 15 plus years now, that mental health and substance use disorders usually are co-flyers. They go hand in hand. And just hearing from the three of you, three stories, and there's a lot of trauma there. You all mentioned childhood traumas and previous traumas, and trauma has a lot to do with that underlining with substance use disorder. So I don't know if Dr. Hahn wants to follow up with what his experiences with individuals with mental health, substance use disorders, and disability, all with that whole intersectionality. And treatment's different for every individual. So I just what are your comments on that? Just your general, just from being in practice.
Yeah, first I have to say, I've been like writing notes because I've learned so much from listening to all of you. It's just been really humbling and amazing. And I agree, these insights, I have to transcribe this later. I'm sure it'll take me 15 minutes to type, but I really just want to say thank you. And, one of the themes too about adverse childhood events, that there's a lot in medicine now about focusing on what they call ACEs, adverse childhood events, so that we know that people that have had experiences such as domestic violence or sexual abuse or assault or witnessing a death or a murder or a parent that's had a divorce or domestic violence, those individual events dramatically increase your risk for substance use disorders in the future, and they increase your risk for heart disease, chronic lung disease. So it's not just behavioral health, but also physical health issues. And so one of the things that I feel that I'm glad about medicine too in the last 15, 20 years is that there is becoming more emphasis on addressing ACEs and also in kind of compelling the medical community to take responsibility for screening for them, to trying to help support people, not only in recovery, but with other behavioral health issues and medical issues. And I actually think that it's sort of pushing the medical community to be more empathic, because one of the things that I found really rewarding in doing work with MAT and with behavioral health is that it's been very liberating. There's such rigidity built into medicine. As all of you know, there's a rigidity. It's very hierarchical. It's very rule-oriented, protocol-oriented. And physicians are trained to be in control. You set rules, you set boundaries, you do all this. But the thing about working with people in recovery is that it's liberating, because it really tells you that we don't have that much control. I mean, it's really about the relationship, as Sarah said. It's about the relationship and helping people come to grips with what they can do following that harm reduction model. I find harm reduction useful. It's a very powerful perspective, not just in looking at addiction, but in everything, in hypertension management, in diabetes management. I mean, you wear seatbelts. That's a harm reduction intervention. So it's all, I think pretty much everything we do in life is about harm reduction, and it's a very useful paradigm to help us loosen our brains a bit and try to work with people and not just make it about control and about setting rules and people leaving the office being unhappy and providers being frustrated. I mean, medicine and medical relationships have to be about way more than that to help people. So.
Thank you, Dr. Hahn. Thank you for just being a vulnerable doctor and sharing with us that, it's not always about being in control. I think people like to hear that and just appreciate the fact that you just said that out loud as a doctor. So thank you for just being vulnerable. I just want to also just give everybody else, Jess, Sarah, and Naomi, just 1 minute wrap up of any last minute thoughts before we just open up for some Q&A. If anybody wants to, just one last thing you just want to say about any myths or misconceptions you just want to clear up before we open it up to people. And Sarah, I'll let you go first, then Naomi, and then Jess.
I don't know if I have any misconceptions to clear up, but I would like to add one thing about the disability piece. I was at a 12-step meeting on Monday this week, and there was a woman who came for the first time. She was deaf. I know just the tiniest bit of ASL, like the alphabet and a couple words, so I was able to say hi to her. And she told me that she was desperately searching for 12-step meetings that have ASL interpreters, because she's just sitting in meetings. Just how do you get something out of a meeting if you can't actually hear the stories that are being told in a meeting? That's crucial. So that was just sort of a synchronous moment of this was already on my mind because of this panel. And then somebody walked into the room and I realized how few resources I had to offer her in terms of that meeting. So I just wanted to appreciate Naomi and your story and giving us that perspective that makes me think even more about what am I doing to be an inclusive part of this community, and what could I be doing more? So thanks.
Thank you, Sarah. Naomi, do you have any last? I'm sure you do.
You're very welcome, Sarah. And that, just to piggyback off your thought, that's precisely the issue. And as Bethany mentioned, a lot of AA and NA, they're being held in church basements. The one I was going prior to my injury, I remembered, I'm like, wait, they have an elevator. So then I decided to go anyway, and the elevator doesn't work. I was so embarrassed. They had to carry me down the steps. And because I was already there, I allowed it, but I never went back because of that. And so even though I'm not, I don't want to say a huge fan. I definitely respect what AA and NA does. I just felt I didn't need it as intensely anymore. And I just started doing online meetings instead. I just never went back. And that was exactly why. And so there are a lot of people in the disability community that are struggling with these resources. And, that's why I, joined forces with Disability Pride, because at least our online meetings do provide ASL interpretation. I believe Vicky put it in the chat, every other Tuesday, we're always there, ready and pumped to get and give the recovery that this entire community needs. And you don't necessarily have to be disabled, but if you know someone that happens to have a disability and you're looking for resources and support, how to support that person, you're also welcome to join our meetings too. I think that they are a vital key points to being able to make recovery accessible. And it's just important. And so many things that everyone said resonated with me, but especially when Sarah mentioned about being able to understand the relationship between the whether it's the substance abuse or the medications. I completely resonated with that, because when I finally understood that I had to heal my traumas in order to overcome, the reason I continued to use wasn't because I was bored. It wasn't, I kept trying to numb. And so once I no longer had that pain to numb, the memories aren't gone, but the pain absolutely subsided once I was able to get the therapy that I needed to work through those underlying causes. And it opened up a whole new world to me, where I was able to go after my dreams, my goals, my aspirations, doing all the things that I had prior missed, doing all the things that I had neglected. I lost my children. I had lost custody of my children at one point. I lost my job, my car, my house, everything. Experienced homelessness several times. And I kept going back. And now I understood why. So once I was able to heal that trauma, now I'm able to stay firm on the ground in my recovery and go after all the things that I had previously neglected. And so I just want to say thank you to everyone that spoke before me. You guys are amazing. I'm so grateful to be a part of this panel and that I was here today. So thank you.
And we are grateful for you joining us. So thank you, Naomi. And Jess, any last things you want to wrap up with?
Well, I was, I was thinking about a deaf person at a meeting. I was thinking about you, Naomi, having people help you down the stairs in a way that was like not comfortable for you. And I find it very powerful, people's desire to heal, the hard work that people do in a society that is like really condemns those of us who have this condition, while at the same time celebrates alcohol use and lots of other types of self-destructive behavior. And I wanted to mention that the Pittsburgh Recovery Walk this year is downtown in September, and we will have an ASL interpreter, and the route itself is wheelchair accessible, and one does not have to walk at all. In fact, many people who just don't really like walking don't walk. But I think that probably all of us who have this experience would say that we have kind of different recoveries. And that's what is kind of exciting. It seems like all of our stories are still unfolding. But I wanted to rep the reality of people in recovery who are not totally abstaining from alcohol and other drugs. That's not my experience. I strongly believe that the issue, as Sarah said, is in my relationships with alcohol and drugs. And I don't really want to work on those relationships anymore. I just want to abstain because I got enough trouble in my other relationships. But I do know plenty of people for whom their relationships with alcohol and drugs have become healthier. And I want to hold up those stories too, because I think particularly addiction treatment programs and 12-step support rooms can really dismiss and silence those stories. I think the idea is there's many paths to recovery and there's many recovery destinations, and in some ways it's less a destination than an ongoing journey. So.
Thank you, Jess. That was beautifully put at the end. It's the journey. I like to say that I live with general anxiety disorder, and I'm like, I'm not, and you say lived experience. I'm like, no, I'm still living this experience. This experience is still continue going on. It's just not like disappeared. So I really appreciate that it's a journey and that we're all in it together, and the inclusivity and just hearing these voices and hearing everything you had to say today was very insightful and very great. So I just want to open it up to anybody in the audience. If you have any questions for our panelists today, either I think you can unmute yourself or you could throw it into the chat. Or if not, if you have nothing to say or no questions, we can all go on our afternoons. And I know there's a 12 o'clock mindfulness thing, I do believe, after this. I could be wrong, Vicky can tell me
That's
if
right.
I'm wrong. I'm right. Okay. So you can get some mindfulness after hearing these stories and just, reset yourself. But again, I really encourage everybody to check out different types of mutual aid groups that are out there. And I feel like I have now a challenge from just to hear these stories and making sure that us as Staunton Farm Foundation, that we make sure that when we're thinking about funding going in the future, that these treatment facilities, these places are ADA accessible, that we're making sure that we're being inclusive as possible. So that is a challenge that I have accepted just from hearing Naomi's story from the first time I heard it in May. So I don't know if now Naomi knew that I took that, or I saw that as a challenge, but I accepted it. And I'm just now making sure that is in back of our minds every time we're thinking about grant funding. So I appreciate your story. So thank you. Now, does anybody in the audience have any questions? If not, okay, we do have some questions. I'm Mark. I see your
Yes.
hand raised.
Yes, hello, my name is Mark, and I want to say thank you to everyone for your fine presentations. This is all new to me. I want to say thank you. I learned a lot, and I want to offer you blessings on your continued recovery and journey. Thank you very much.
Thank you, Mark. All right, next, Erin.
Yes, hi everyone. So before I ask my question, I just want to thank you all for sharing your wisdom and experiences. This has been really, really moving, and I can't thank you guys enough. So Dr. Hahn, I wanted to ask you, what advice would you give to other physicians who don't want to be part of the problem in terms of not overprescribing opiates while also not neglecting the needs of chronic pain patients, who in my view have kind of become collateral damage to a degree in the effort to reduce opioid prescribing?
That's a great question. I think the advice I would give everyone, let me take a step back. So there's, interestingly, probably about 7 or 8 years ago now, there was a big nationwide push to educate all physicians about responsible opioid prescribing. It was called basically like an opioid stewardship campaign. So they were requiring physicians to do extra education to make sure that we were aware of the opioid overdose epidemic and about responsible opioid prescribing. And it was pretty effective because most physicians did this. They were required to do this to maintain board certification in their licenses. Opioid prescribing went way down quickly. However, the number of overdoses continued to rise and in fact shot up because then people were turning to illicit opioids and heroin and fentanyl. And so it really only kind of like helped. Honestly, some physicians feel like I'm doing my part because I'm not going to contribute to this. Yet people were still dying, and in fact, the deaths accelerated. And so I think what I would advise people is, number one, there are many really good evidence-based guidelines about how to prescribe opioids. I think in a very more effective and conscientious way. That's number one. Number two, prescribe MAT. So I think if you receive the training on how to prescribe Suboxone, Vivitrol, make conscientious referrals for people for methadone, I think it starts to change your brain a little bit. It starts to make you look at patient care more holistically. That it's not simply like, I can't give these people opioids, because they're going to get addicted and then it'll be on me and it's a problem. I think it really helps you look at a person holistically. Like if people, sometimes you'll see a patient that comes to you on a lot of opioids already, and they have serious chronic pain issues, and they need opioids for pain control. But you may recognize that they also have an opioid use disorder, and maybe Suboxone. Using Suboxone can treat both. It can be effective for both. There are a lot of trials right now where people are studying Suboxone use for chronic pain in addition to using it for opioid use disorder. So I think this is really helpful because this is just in the last 5 to 8 years, we're seeing more research in this arena. And I think this is coming with that perspective that, look, this is our responsibility. It's not simply don't prescribe opioids. It's like we have to take care of people. They're human beings. And these are important issues to not shy away from, or worse, to just ignore. So I would say my advice would be learn how to do both. Learn to be a responsible prescriber, learn how to identify and talk to people about signs of addiction, and learn how to prescribe MAT, because then it gives you a more holistic point of view that I think you can truly help people better. So
Thank you for that very thoughtful answer. Yeah, I'm very happy to hear that there's research going on in that area.
I was going to say, Dr. Hunt, I've read research in Europe that in studies in methadone being used for chronic pain, and it's been used very effectively. And we're the United States, we catch on last. So when it's innovative and seems a little bit different, we usually are the last to adopt, which I noticed. In Pennsylvania, we'll be the last state to adopt it all. So that's usually how Pennsylvania goes. So since I have no more hands raised and there's no questions in the chat box, I'm going to kick it over to Izzy to close us out.
Okay, thank you so much. I want to thank Joni and Bethany and the ASL interpreters for coming on, and for Staunton Farms Foundation for putting this on, and Tina Calabro of the WPDHAC. Thank you everyone for coming. Join us for our mindfulness session starting at noon. Have a good one, everyone.
And thank you to our wonderful panelists. I am so grateful for your presence today. So thank you. And thank you for everybody who showed up. Have a wonderful Wednesday afternoon.
Bye, everyone.
Bye-bye.